And glad that some of you all have come back again for this session, for the second session of the ECG. So I think the last time we stopped at this slide here, where we talked about Torsades. Well, obviously, if you remember some of the principles that we talked about for the ECG reading, is that we need to know the axis, we need to know which direction electricity is going through, as well as being able to recognize right bundle from left bundle. These are very basic things, but it can help us a lot understand certain ECG findings that we will go through. So the rest of the slides today that we're going to talk about will be some cases, and then I'm just going to briefly mention some points about certain diseases that we may encounter when we look at ECG. Okay, so I'm sure, like I said, the last time, those of us who have signed up for this online session, some of you may be very junior, some of you may be very senior, so we will try to pitch this somewhere in between. Okay. So the next case that I wanted to show you is this ECG. Okay, if you look at it carefully, this is a 56-year-old man. He came in with palpitations, feeling breathless, sweaty, and you take his blood pressure is 130/70. So he's still alert. The blood pressure seems normal, but if you look at the ECG, it looks bizarre. Yeah. So one of the things that you want to notice on this ECG is that there is a wide complex tachycardia. Okay, would you agree that there's a wide complex tachycardia? Just looking at it, it looks like ventricular tachycardia, but then if you carefully look at the waves, you will find that there's some irregularity to it. So the RR interval here and the RR interval here is obviously different. You know, the RR interval here is short, here is longer. So most of you may know this already, but if you look at this kind of ECG, broad complex tachycardia, then you have to think about one diagnosis. Okay, but the fact is that the heart rate is going very, very fast and the patient is symptomatic. So you need to cardiovert this rhythm as soon as possible. You can cardiovert it with medication if the patient is stable, or you can use electrical cardioversion. Okay, so this is after this patient underwent synchronized cardioversion of his wide complex tachycardia, and this is his baseline ECG after cardio. And most of us will also recognize this ECG. Those of you who are a bit more senior will recognize this ECG. So this is an ECG in sinus rhythm. If you look at the P wave, there's P wave, and then there's QRS complex. And then if you look at this, the beginning of the R wave here, you will see what we call a delta wave, or what we call pre-excitation. Okay, that means there's a very short interval between the P wave and the R wave, the short R interval, and then an upsloping segment between the P wave and the R wave, which is what we call a pre-excitation pattern, or most of us have heard of the delta wave. Okay, so this, the delta wave here, you can look here is delta wave, delta wave. But this is a Wolff-Parkinson-White picture. If you look at the inferior leads, you see this kind of pseudo, what we call pseudo Q waves. Okay, so these are not, this is not a patient with a myocardial infarction, but this is a patient with Wolff-Parkinson-White pattern. Okay, and you know that in Wolff-Parkinson-White pattern, there is an accessory pathway, right? There is our normal atrioventricular node where the electricity passes through, and then there is an accessory pathway. And the accessory pathway in Wolff-Parkinson-White is many times much faster. It conducts faster than the atrioventricular node because the refractory period in the accessory pathway is shorter. Therefore, the electricity goes through the accessory pathway faster, and that's why the QRS complex comes early, and therefore the PR interval is short. Okay, and because the accessory pathway is faster, I mean, I'm talking to medical students here, but I'm sure the rest of you know, because the accessory pathway is faster in conduction, if you have atrial fibrillation, which is what this ECG is, Okay, if you have atrial fibrillation, the atrial fibrillatory waves, which could be between 300 to 600 beats per minute, a lot of these electricity from the atrium can conduct through to the ventricle through the accessory pathway. And if the refractory period of the accessory pathway is shorter, therefore you get a very fast atrial fibrillation. And these patients can deteriorate into ventricular fibrillation quite easily. And that is why in Wolff-Parkinson-White syndrome, there is some risk of sudden cardiac death. Okay, so in patients like this, where you recognize this is Wolff-Parkinson-White with atrial fibrillation, you have to try to quickly cardiovert them before they degenerate into ventricular fibrillation. In this patient, we used electrical cardioversion. Atrial fibrillation, you don't need to use very high voltages. You can use a biphasic 50 joules to 100 joules, and most of the time, you can do safely an electrical cardioversion for these patients. You can also use chemical cardioversion. The safest medication to use would be IV amiodarone, okay? Because if you use IV verapamil, for example, you may block the atrioventricular node further, and therefore the conduction down the accessory pathway becomes even more, and the heart rate can actually go even faster, okay? So in this kind of cases where you recognize atrial fibrillation with Wolff-Parkinson-White syndrome, you don't want to give them a beta blocker or calcium channel blocker. So no verapamil, no beta blockers. IV amiodarone may be safe enough because it can also block the accessory pathway. But if the patient is unstable or even slightly unstable, the best thing to do is use electrical cardioversion. Okay. This is type B Wolff-Parkinson-White syndrome. I won't go into type A and type B, but I'm also not an electrophysiologist. So I won't pretend to know terribly a lot about you know, how to sometimes localize the accessory pathway. So this is Wolff-Parkinson-White with atrial fibrillation. Okay, this is another example of a patient with Wolff-Parkinson-White and atrial fibrillation. So this is not ventricular tachycardia. When you see this ECG, the first thing you think is ventricular tachycardia. I mean, it's okay because you will probably just give the patient amiodarone or shock the patient. The end result will be the same. But you know, you need to recognize that there is some irregularity in the RR interval. And this is a patient with, if you have a right bundle branch block pattern here, this is a patient with a type A Wolff-Parkinson-White syndrome. Okay. This is another patient that was admitted into our hospital. This was many years ago. This is a 20-year-old male. He was actually doing his national service in Singapore. We do national service. He was very thin, BMI of only 15, and he had 2 episodes of brief seizures at home, according to his mom. Okay, so he was admitted, and this was his ECG. Can you tell that there is some abnormality on this ECG? First of all, you see that it's sinus rhythm. Sinus rhythm and fairly bradycardic. But if you look at the QT duration here, you can tell that the QT duration is a little bit prolonged. Okay, if you correct it for QTC, maybe it is within normal. But overall, you know, ST segment here, the T wave, it's a little bit cold, a little bit funny. Okay, so what's the next what's the next test to carry out? Okay, so the blood test to carry out, obviously, when we see this kind of patients, we will run some basic blood tests like renal function, liver function, blood counts and such. But the blood test that really you're interested in is potassium, calcium, magnesium, okay? Because you want to know whether there is something in the blood test that can prolong this QT interval. So the resident or the trainee registrar was very good. He put the patient on telemetry and ran the test, found that the patient's potassium was low, and then ran some potassium to correct. The same night, this is the patient's real telemetry. in ICU, the medical officer on call was sitting chatting with the nurse in front of the telemetry station, and he saw this rhythm. So the patient actually went into Torsade, okay, and they quickly contacted the ward and they chopped this boy out of the polymorphic VT, and he survived. He was only a 20-year-old boy. If he was not on telemetry and if nobody saw this, he probably would have died that night. Okay, so it turned out that this patient had hypokalemia because he was actually a bulimic patient. So he had anorexia bulimia, and he was inducing vomiting, and he vomited so much that he was hypokalemic and then caused a long QT, and therefore this polymorphic VT. It's really thankful that we managed to save him and he didn't die at home. And the next thing to do, of course, is to refer him to a psychiatrist. Okay. So causes of prolonged QTC, we know that there are congenital causes, the Javel-Lange-Nielsen syndrome, Romano-Ward syndrome, which comes with deafness, if I remember correctly, or it could be idiopathic, okay, and can be inherited in the family. And therefore, if you have a patient with prolonged QTC, you think it is idiopathic, then you need to kind of screen or encourage them to screen the rest of their immediate family. It can be, of course, due to ischemia. So in patients with post-acute coronary syndrome, as well as patients with ischemic heart disease, you can get long QT. In hypokalemia, hypomagnesemia, hypocalcemia, hypothyroidism, and in this boy, the anorexic bulimic patient or the starvation patient, you can get prolonged QTC. Okay. I think the common medications that we use will be imidazole, antibiotics like quinolones, as well as erythromycin, the macrolides. Although probably the safest macrolide I would say to use will be azithromycin, and the safest quinolone probably will be levofloxacin, because these two tend to not cause prolonged QTC as much as the other macrolides. And thiazines, tricyclic antidepressants, haloperidol, SSRIs, a lot of the psychiatric antipsychotic medications can cause long QT. Cisapride, domperidone. I have a patient, actually, I was just discharged her last week. The gastroenterologist insists that her domperidone is harmless and she should continue it. Of course, she's very symptomatic from her gastric reflux symptoms. But every time she gets back onto domperidone, she has a QTC of more than 500. And then she actually on the telemetry has non-sustained ventricular tachycardia of maybe 4 or 5 beats. And she can't tolerate beta blockers. So, I've asked her to again stop the domperidone, and I've got to write to the gastroenterologist. So domperidone is something that we have to be careful about because it is very commonly used. It is a little bit more risky in children. You may have heard of children coming in with vomiting and given domperidone and then going home and having sudden death. Domperidone of more than 30 milligrams per day is it is associated with sudden cardiac death, and in Singapore, domperidone is officially contraindicated to give if it is more than 30 milligrams a day. Okay, so that's something that to note. Yeah. For other drugs like diuretics, organophosphates, there are a lot of medications that can cause long QT. I'm sure we all know this. Okay. There's a slide on tachycardia. As we talk about torsades, we talk about atrial fibrillation, we talk about ventricular tachycardia. We've all seen this as well if you've gone for ACLS. When you have a tachycardia, patient with tachycardia, you want to determine whether it's regular or irregular. So if it is regular and narrow complex tachycardia, then the diagnosis is either sinus tachycardia or supraventricular tachycardia or atrial flutter. Okay, if it is regular, narrow complex. If it is broad complex and regular, then it is usually ventricular tachycardia or supraventricular tachycardia with aberrancy or supraventricular tachycardia with pre-excitation. Okay, so What this means is supraventricular tachycardia with aberrancy means that the patient has a pre-existing bundle branch block, and when they go into SVT, the SVT is broad complex QRS. Pre-excitation means that the patient has Wolff-Parkinson-White pattern, and during the tachycardia, is the pathway goes through the accessory pathway, and therefore you get a broad complex tachycardia. So in Wolff-Parkinson-White syndrome, don't be tricked because there is an autodromic and an antidromic tachycardia. So if the electrical activity goes through the AV node and comes back through the accessory pathway, then you will get a narrow complex SVT. If the electricity goes through the accessory pathway and comes back through the atrioventricular pathway, then you will get a broad complex SVT. Okay, and then if the rhythm is irregular and narrow complex, then you have to think about atrial fibrillation or flutter with varying block. And just now, I showed you an irregular tachycardia with broad complex. Then you've got to think about pre-excited AF. That means Wolff-Parkinson-White with AF, or sometimes Torsades or polymorphic VT can sometimes be a little bit irregular. Okay, so these are some of the things that you have to think about. Now, in theory, it's easy, but in practice, sometimes it's quite difficult to determine what is what. Okay, so I'm just showing you this ECG from last week's patient. It's quite obvious. I think most of you can tell that this is tachycardic, it's narrow complex. You don't really see the P waves. If you can imagine, this is a retrograde P wave here. This is a retrograde P wave here. Possibly this bump, this very subtle shape here is a retrograde P wave. And so this is a supraventricular tachycardia, and it is an AV nodal reentrant tachycardia. Okay, so if you convert this patient, so typically you try Valsalva maneuver, you try carotid massage, and if it fails, you give a shot of adenosine. You can give 6 milligrams of adenosine through a large bore vein and flush it down with 20 ml of water or saline, and then you can step up to 12 milligrams. If the patient doesn't convert, then you can use verapamil infusion. And if the patient still don't convert, and you see that there is may sometimes be a flutter that is behaving, that you think it is a AV NRT or AV nodal reentrant tachycardia, then you can use amiodarone or you can use electrical cardioversion. Okay, so essentially convert this, and after conversion, if the ECG is normal, then you call this an AV nodal reentrant tachycardia, which is the most typical type of SVT. But if after conversion you see a delta wave or pre-excitation wave, then this is Wolff-Parkinson-White syndrome, which is slightly different. Okay. Quite complex tachycardia. How do you tell whether it is VT or SVT? So how do you tell VT or SVT? This is a very old slide that gives you some clues. So first of all, even before looking at the ECG, the patient is the most important. Okay, if it is a 60-year-old guy with diabetes, you know, with hypertension, who's a smoker, then by all means, a broad complex tachycardia is VT until proven otherwise. If it is a 20-year-old boy with broad complex tachycardia, then you've got to think, is this SVT or is this VT? Okay, so if the patient has a high risk of ischemic heart disease or, you know, disease of the myocardium, then you know that most likely it is ventricular tachycardia. Okay, the other things to look at, of course, is whether there is atrioventricular dissociation. Okay? So in VT, the ventricle is being triggered on its own, and the atrium is doing its own thing, and therefore there is atrioventricular dissociation. In ventricular tachycardia, the QRS is broader typically, but there are some caveats here, so don't be fooled. In ventricular tachycardia, the axis is usually extreme. Now, what is extreme axis? So if you look at the axis, it's either left axis deviation, okay, or deviation of axis to the right. I didn't really put up a slide on how to look at axis, but I think most of you in the basic ECG training will know how to look at axis. If the axis is extreme axis means axis between, if you look at a cross, between 270 degrees to 360 degrees. Okay, so if you are facing me and I'm across, then the axis is on my right upper zone. Okay, so if the electricity is going towards my right upper zone or towards northwest, then it's extreme axis. Okay? And obviously, if the ventricular focus in the ventricular tachycardia is coming, for example, from the left ventricular apex, then the electricity will be moving up the ventricle towards the right upper. Okay, so it will be towards the northwest direction, and that's what we call the extreme axis. Okay, and then the QRS morphology, if you look at it, if you look at the right bundle branch morphology here, in VT, the right bundle branch morphology looks like a suspicious right bundle branch. In SVT, the right bundle branch morphology looks more like a right bundle branch. Of course, we say that in the rabbit ear, the first rabbit ear is shorter, the second rabbit ear is taller, is more likely SVT. The first rabbit ear is taller and the second is shorter, is more likely VT. An easy way for me is, it looks like right bundle branch, it's probably SVT. If it has an image of right bundle branch, but it doesn't look like a typical right bundle branch, then it is more likely a VT. Okay, and similarly for left bundle branch. Fusion beats is important. If you see a fusion beat, that means a fusion between a ventricular focus and a normal focus that goes down the AV node. That means a QRS morphology that looks different from a normal QRS, different from the VT QRS, then that's a fusion beat. The fusion beat is actually a sign of AV dissociation. Fusion beat is a sign that the atrium and the ventricle is doing, it's activating on its own. And lastly, concordant pattern. What does concordant pattern mean? Concordant pattern means in the V leads, that means in the precordial leads, if all the QRS is pointing upwards or all the QRS is pointing downwards, then it's more likely to be VT. If it is SVT, it will be either a right bundle branch block pattern or a left bundle branch block pattern. So half of the R waves are pointing upwards, half of the R waves are pointing downwards. That is a discordant pattern. Okay, so if it is a concordant pattern, where all the R waves are pointing the same direction in the precordial test leads, the V1 to V6, then it's more likely to be VT. Okay. So what is this? Is this VT or SVT? So how do we tell? Sorry. So how do we tell whether this is VT or SVT? This has a right bundle branch type of pattern. Okay, if you look at V1 and V6, okay, is it concordant? It's not absolutely concordant because the S waves are also fairly in V4 to V6, and then the R waves, of course, is tall in V1 up to V4. Axis is not really extreme, and then if you look at these spots here, these may be retrograde P waves, and it's quite consistent that every QRS has a retrograde P wave. You don't see obvious AV dissociation, you don't see capture beats. More likely than not, this is SVT with aberrancy. Okay, the picture that I got this from says that it's SVT with aberrancy. Okay, but to be honest, sometimes it can be really quite difficult to tell. Okay, and this. Okay. ECG. Is this SVT or VT? Number one, you look at the V1 and V6. This looks like a right bundle branch block pattern. It looks quite typical of a right bundle branch block, but if you see the first R wave is taller than the second R wave, QRS is not very broad. Okay, you know, it's broad enough to say that this is not a narrow complex tachycardia. It's a little bit of a borderline broad complex tachycardia. The axis is actually normal. Okay, so the axis is an inferior axis. The R waves are all positive, pointing downwards. maybe a little bit more right axis deviation. And then is there AV dissociation? Maybe you see this T wave and this T wave is a bit different. This T wave and this T wave, is it different? This one also different. Maybe there is a P wave that is going in and out that is making the pattern a little bit different. Okay. So this kind of patients frequently come to A&E. They're quite stable. And then the doctor in A&E will think that this is SVT and they will give adenosine, and then nothing happens. Okay. When they give verapamil, the patient converts. So the question is this really SVT? It's not actually SVT. Okay. This is what we call idiopathic vesicular VT. Okay. Some of you will have heard of this condition where it is a ventricular tachycardia, but the focus of the ventricular tachycardia comes from the vesicle. That means come from the septum. And therefore, when it comes from the septum, either the left anterior vesicle or the left posterior vesicle, that means it comes from the left bundle branch, either anterior or posterior, where the focus of the VT is coming from. Therefore, when it goes down, it gives you a right bundle branch top pattern. And because it's coming down the septum, the axis is quite normal. Okay, so frequently this is mistaken as SVT, but it's actually a form of ventricular tachycardia. And it is very sensitive to calcium channel blockers. So if you give them verapamil, they can convert. But of course, you can give them amiodarone, they can convert, or you can do an electrical cardioversion and they can convert. Okay, but adenosine will not convert this rhythm because it has nothing to do with the AV node. Okay, so this is a vesicular VT. So try to remember this. Sometimes we call it Dalen-Wu VT, but basically, basically it is a vesicular VT because the VT comes from the vesicle. Okay. This is a patient who saw me a few months ago. A 40-year-old lady went for screening treadmill, and if you look at her treadmill, she goes into this kind of non-sustained ventricular tachycardia quite often during the treadmill. She's totally asymptomatic. She has never fainted before. She has never had palpitations before. And it only happens when she exercises. Okay. So if you look at the pattern of the VT in V1, it's also right bundle branch. Okay. And if you look at lead 2, which tells you the axis, it's pointing downwards axis. So this is the same condition as idiopathic left ventricular VT or vesicular VT. And every time she exercises, because of the catecholamine and the adrenaline, it induces the VT. Okay. So she had an ablation done recently, which was successful, and hopefully she doesn't have this coming back again. This is a 30-year-old man presenting with atypical chest pain. He has intermittent palpitations and had one episode of fainting before. And if you look at the ECG, I think the most obvious abnormality, and most of us will recognize this, is there is some ST elevation in V2, a bit of in V1, and a little bit in V3. Okay, there is no reciprocal change. Okay, no reciprocal change, but some ST elevation in V1, V2, and V3. And this ST elevation, what we call a coved ST elevation or a convex ST elevation. Okay, so it's a convex ST elevation, and this is a typical pattern, as you would know, of Brugada syndrome. And what is one question that you can ask? Of course, whether you have family members who have had sudden cardiac death or who require an implanted defibrillator. Okay. So what is Brugada syndrome? I'm not sure whether this is common in Myanmar, but we know it's quite common in Thailand. It's not as common in Singapore, but we still see it once in a while, especially the type 2. So the Brugada pattern is basically an ECG pattern of pseudo right bundle branch block with ST elevation in V1 to V3. And it's called Brugada because it's described by the Brugada brothers. And there are 3 types. Type 1, which is the most sinister type, has a coved or convex ST elevation with T inversions. That was the picture that I showed you earlier. Type 2 Brugada pattern has a concave ST elevation, so it looks like a saddle-shaped ST elevation of more than 1 millimeter in leads V1 to V3. And type 3 is concave ST elevation that is less than 1 millimeter. Okay, so type 3 is actually difficult determined because a lot of patients have this kind of concave ST elevation of less than 1 millimeter. ECG changes may be transient. This is something that you need to know. It may be reviewed by sodium channel blockers. For example, if you give flecainide, for example, if the patient, it can also be reviewed if the patient has vagal stimulus. For example, if the patient is in pain and the vagus nerve is stimulated, or after a very heavy exercise and the patient stops and the vagus nerve is stimulated. Okay, it can be frequently triggered by fever. So sometimes when the patient comes with fever, we can see these ST elevations, either type 1 or type 2 type of pattern. It can be triggered by beta blockers, by hyperkalemia and hypercalcemia. Okay, so these are some of the things that you have to remember, especially fever. So if you see a patient with type 2 Brugada pattern and they're asymptomatic and we decide not to treat them, we always need to remind them to keep the fever down. When they have febrile illness, their paracetamol, you do their tepid sponging and get the fever down. Okay. So this is a example of a type 2 Brugada pattern. If you see this concave or saddle-shaped type of ST elevation in B2 and a bit in B3, and this is more than 1 millimeter. So if it's less than 1 millimeter, it's type 3. If more than 1 millimeter, it's type 2. Now, the question is what to do with this type 2 Brugada patient. It's difficult. So if they have fainted before, or had syncope before, or have a family member with sudden cardiac death, then you need to determine whether they can go into type 1. Then you do a flecainide challenge test and see if this pattern becomes a type 1 Brugada. If that is the case, then you put in an implanted defibrillator. Okay. If your flecainide challenge test is normal, it doesn't go into type 1 pattern, then you just leave them alone. Okay. If you see type 2 Brugada pattern and the patient is totally asymptomatic, patient has no family members with sudden cardiac death, then many times we just leave them alone. We don't even do the flecainide challenge test. Okay. If you see a type 1 Brugada who has syncope before, then you will need to put in implanted defibrillator. If you see a type 1 Brugada with no syncope before and no high-risk features, especially if the type 1 only happens when they have fever and it resolves when they are well, then it's a bit of a difficult decision. Most of the time we just sit, watch, and don't do anything to the patient. Okay. And one thing to remember about Brugada is because it is triggered by vagus nerve stimulation, the ventricular tachycardia or the VT that happens during Brugada usually happens at night when patients are sleeping, and so they can have sudden cardiac death in their sleep. And generally, we don't give them beta blockers. Okay. Brugada syndrome is also called a sudden unexpected nocturnal death syndrome because of what I just mentioned. It is a sodium channel abnormality due to SCN5A mutation. We don't typically run the mutation or the genomic testing. And then the diagnostic criteria is all these things. I don't think we will go too much into this, but basically just very quickly, if they have documented VF, then it's very high risk. If they have documented VT, they're also high risk. If a family history of cardiac death, high risk. One ST elevation in family members. If you can induce VT with electrophysiology study, although this is a little bit controversial, or if there are unexplained syncope or this nocturnal agonal respiration, which we usually don't test for, but if they have these features and they have type 1 Brugada, then you should put in an implanted defibrillator. Okay. This next patient, 86-year-old gentleman with dizziness and syncope. Look at the ECG. There are a few things that you note. One, you see the QRS complex is broad and is slow. Okay, so it is bradycardic. QRS complex is regular and slow. And when you see a very slow, regular, complex QRS, you have to think about complete heart block. Okay, and then you look for the P waves. Where are the P waves? This is the P wave here. Probably a P wave somewhere hidden here. There's a P wave here. Probably one here, here, here. There are P waves. The P wave rate is not too bad, maybe 70-something beats per minute. And the P wave and the QRS is dissociated, so this is complete heart block. On top of that, on this ECG, you see this spike. This spike here, this spike there. you see that the spike is spiking when it's not supposed to spike. Okay, so you have a QRS here, and then you have a spike here. If you have a QRS, you should not have a spike immediately after. And then you see spikes here, but the spike here is not causing a QRS. Okay, and the spike is just going on its own. So this is basically a complete heart block with a pacemaker, a patient with pacemaker, but the pacemaker has failed. The pacemaker cannot sense the intrinsic QRS. It doesn't know that the patient has its own QRS complex and that yet it still paces, as well as the pacemaker cannot capture. The pacemaker, when it paces, it cannot trigger a QRS. When does this happen? This happens when the pacemaker lead has dislodged and is no longer in contact with the ventricle, or more likely, the insulation of the pacemaker lead has been damaged because the pacemaker may be one that is very old, and therefore the resistance in the lead is too high, and the pacemaker is not functioning well. This is a 24-year-old female with syncope. Her brother has sudden cardiac death at 25 years old. This is her ECG. We all can recognize this, I believe. This is the R wave in V5. It's quite tall, and the S wave in V2, very deep. There is some ECG voltage criteria for left ventricular hypertrophy. There is ST depression in V4, V5, V6, and in the inferior leads. So this is a strain pattern. Of course, this could be due to ischemia, but in a 24-year-old female, you would not think that the patient has coronary artery disease. This ECG is much more typical of left ventricular hypertrophy with strain. Sometimes digoxin effect can also cause this kind of ECGs. If you look at the 24-year-old female, no medication, syncope, ECG, it is hypertrophic cardiomyopathy until proven otherwise. Okay, so which test to order next is an echocardiogram. For hypertrophic cardiomyopathy, half of all cases are familial, means that they run in the family. There's a risk of sudden cardiac death due to VT or VF, and it is due to mutations in these genes. Okay, in the cardiac myosin gene, troponin T, tropomyosin, myosin binding gene. Not really important to know all this. Consent for genetic testing. Genetic testing is becoming more and more available and more being used nowadays. So basically, there is left ventricular hypertrophy. There is usually asymmetry whereby the septum is more hypertrophic than the posterior wall of the left ventricle. And so usually the septum is more hypertrophic. And because of the septum, there is more hypertrophic when the ventricle contracts. It pulls the anterior mitral leaflet, and therefore there is systolic anterior motion of the septal mitral valve leaflet, and sometimes this causes mitral regurgitation. Okay, because the septum is so thick, when the heart comes, it pulls the anterior mitral valve leaflet upwards or anterior in the anterior direction, and that can cause mitral regurgitation, and that worsens the heart failure for these kind of patients. Okay, so these patients can also present with heart failure. In the myocardium, there is myofibrillar disarray and fibrosis, and this disarray of the myocardial muscle, as well as fibrosis, this creates a substrate for malignant ventricular arrhythmias, and patient can go for VF. Generally speaking, if the septum thickness is very thick, usually for me, I use 3 centimeters as cutoff. That's the time when you have to think about putting in an implanted defibrillator in the patient to prevent sudden cardiac death. Okay. This one is a patient, 92-year-old lady with history of chronic AF, presents with dizziness and dyspnea. Okay. So this patient is a patient with atrial fibrillation. Now, first of all, you got to look at the QRS complexes. It's kind of regular, wouldn't you say? If you look at the QRS complexes, it's quite regular. So the question is this AF? If it is AF, why is it so regular? Then the second question is there a P wave? If you look at these leads, you can't really see a convincing P wave. Is this a P wave with a very prolonged PR interval. That means P wave with a very severe first degree AV block. Is a P wave, or this part of the the ST segment, or a U wave at the end. Okay, so this could be a U wave, but overall there may or may not be convincing P waves. So this patient possibly is still sinus rhythm with a very prolonged PR interval, and maybe in paroxysmal AF. But whenever you see an AF, why I showed this ECG is that whenever you see an AF in a regular rhythm, regular QRS rhythm, you have to think about complete heart block. Okay, think about complete heart block. Whether this patient is complete heart block or not, we're not sure, because the ventricular rate is quite fast actually for complete heart block. But if you see a regular QRS complex in the AF patient and you see a convincing P wave, you have to think about complete heart block. When there is complete heart block, the focus from the ventricle is no longer by the atrial fibrillation, but it comes from the ventricle itself and usually regular. Okay. This is an ECG of a 54-year-old lady with renal failure, very drowsy, dyspneic, and the blood pressure is very low when the patient presents to you. And you see this ECG. So the question is, what is this ECG? It's broad complex, it's tachycardic, 100+ beats per minute. Most of us will call this ventricular tachycardia, okay? But this is kind of a bizarre ventricular tachycardia. You see that the QRS is super broad. Yeah, it's very broad. The axis is, yeah, I suppose it's a no man's land axis or extreme axis, okay? And by all means, this is like a ventricular tachycardia. But when you see this kind of super broad QRS complex with bizarre QRS complex, this is what we call an accelerated idioventricular rhythm. Okay, an accelerated idioventricular rhythm. And accelerated idioventricular rhythm is usually because of a metabolic cause. Okay, so you have to look for hyperkalemia and you have to look for metabolic acidosis. So in patients with severe sepsis, multi-organ failure, significant acidosis, sometimes they can go into this kind of pattern. Patients with severe hyperkalemia, you can get this kind of pattern. But this kind of pattern, it tells you that the patient is going to die soon. Okay, so unless you do something, the patient is going to die soon. As in, the patient is going to go into asystole. Okay, so the first thing you may want to do is give the patient calcium gluconate, give the patient bicarbonate to try and correct hyperkalemia, correct acidosis as much as possible. So hyperkalemia, as you have been taught in medical school, when the patient is hyperkalemic, the more hyperkalemic it is, it's like you take the QRS complex and the ECG. It's like the ECG is a string, and you keep pulling the string and keep pulling the string. The QRS becomes broader and broader, and finally the string will be totally pulled, and the patient will go into asystole. Okay, so if you see this kind of ECG, you know you have to act fast, otherwise the patient is going to die very soon. Okay, this is a patient with again tachycardia. Is it broad complex or narrow complex? It looks broad complex. It is a left bundle branch block kind of pattern. Okay, left bundle branch block kind of pattern. But this is an example of concordance. So you see that the QRS is pointing all downwards. All of it is S wave, V1 all the way to V5, V6, concordant. It's all pointing downwards. Okay. If you look at the axis, at lead 3 is kind of an equal R wave and an S wave. AVF is pointing towards AVF, pointing towards 2. So pointing a little bit of a left inferior axis, but it's a left bundle branch block. So where is the ventricular focus coming from? So this is VT. Ventricular focus, when it's a left bundle branch block, it comes from the right ventricle. Okay, right ventricle. So when it comes from the right ventricle, you've got to think about this disease. Okay, so this patient is cardioverted, and this is the ECG. If you look at V2, V3, you will see T inversions, V2, V3, V4. Of course, this could be ischemic heart disease, but ischemic heart disease, the ventricular focus is almost invariably from the left ventricle. Okay, unless you have a right ventricular infarct. if the focus is from the right ventricle and after you cardiovert, you see these kind of T inversions in the precordial leads, especially V2, V3, then you've got to think about arrhythmogenic right ventricular dysplasia or ARVD. This is due to fibrofatty replacement of the right ventricular myocardium. And usually if you do an echo, the right ventricle will be dilated. If you do an MRI of the heart, you can see the myocardial tuning and as well as fatty infiltration of the myocardium on the gadolinium enhancement of MRI of the heart. Its prevalence could be 1 in 1,000 in the European countries. In Italy, especially 11% of the sudden cardiac death patients have ARVD. It is familial in more than 30%. So if you see in one patient, you got to screen the family members. More commonly is the autosomal dominant inheritance. And the ECG, you will see T inversions in V2 to V3. QRS complex may be broadened. And then you may see the epsilon wave. I don't have an example of the epsilon wave, but epsilon wave basically is a small positive bump, positive like a P wave, like a small P wave after the QRS, immediately after the QRS. Okay, so you got to do echo, cardiac MRI, RV-gram, and then the treatment is to insert an implantable defibrillator. Okay, a few more slides, just a few more slides. Short QT syndrome. If you have a QT interval that is very short, not common to see this. I personally have not seen one. The short QT syndrome is autosomal dominant pattern in inheritance. Corrected QTC is less than 340 milliseconds. There is an increased risk of sudden cardiac death due to VF, and sometimes the patient can come with atrial fibrillation when they're young. If you see a young atrial fibrillation, you've got to look at the QRS complex, whether it is short. Okay. All right. So this is something that is not very common, but something good to know. This is, I think, my last slide. This is a 70-year-old gentleman with heart failure, postural hypotension, and marked left ventricular hypertrophy on echocardiogram. So 70-year-old comes with heart failure, lower limb swelling, has got lowish blood pressure, postural hypotension, and then when you do an echocardiogram because of the heart failure, you find very marked left ventricular hypertrophy. And then you look at the ECG. You wonder, why is the ECG like this? The patient has such bad left ventricular hypertrophy. If I look at the ECG, if I look at V2, V6, there is no left ventricular hypertrophy. If I look at AVL, there is no left ventricular hypertrophy. Okay. One word on ventricular hypertrophy. You know that there's the Sokolov and the Cornell's criteria. I won't go too much into this, but basically, if you have V2 or V1 with the V6 or V5 R wave, if you add up the boxes, if it is more than 7 boxes, okay, 7 big boxes, then it is, or 35 millimeters, 35 millimeters, then that is suspicious of left ventricular hypertrophy. If you have on top of that evidence of left atrial enlargement, that means an inverted P wave in V1 that is more than 1 millimeter in depth and 1 millimeter in width, then that increases the likelihood of ventricular hypertrophy. The other criteria for ventricular hypertrophy, the Cornell criteria, is when you have a high R wave in AVL. If it is more than 7 small boxes or 7 millimeter increase in the R wave in AVL, is again a suggestion that the patient may have left ventricular hypertrophy. Okay. In this patient with an echocardiogram left ventricular hypertrophy, no left ventricular hypertrophy on the ECG, you have to think about one thing, okay, which is cardiac amyloidosis. Okay, so in cardiac amyloidosis, you have ventricular hypertrophy on echo, but no ventricular hypertrophy on the ECG. Okay, so you have to think about cardiac amyloidosis. So earlier we talked about HOCM or hypertrophic cardiomyopathy. When you see a patient with left ventricular hypertrophy, you got to think about 3 things mainly. One is hypertensive cardiomyopathy. So if the patient has uncontrolled hypertension, then the LVH may be due to left ventricular hypertrophy, may be due to hypertension. You got to think about hypertrophic cardiomyopathy as a genetic condition, and then you've got to think about cardiac amyloidosis. So, cardiac amyloidosis, because of amyloidosis also sometimes affect the nervous system autonomic nervous system, and therefore these patients have lowish blood pressure and have postural hypertension. So when you see postural hypertension, left ventricular hypertrophy on echo, no left ventricular hypertrophy on ECG, then you have to think about cardiac amyloidosis. And when you think about this, you also have to screen for multiple myeloma, because the commonest reason for cardiac amyloidosis is actually multiple myeloma, causing primary AL-like chain amyloidosis. Okay, so a few times we cardiologists have diagnosed multiple myeloma just from the ECG and the echo. Okay, thank you. So thank you very much for the attention.